Hi, this is Colin Hung with Healthcare IT Today, and I'm sitting down with Mike McSherry, CEO of Xealth. Mike, thanks for being on the program today.
Hi, Colin. Great to see you again.
Yeah, now we were talking just before how we missed seeing each other because we usually at least bump into each other at HIMSS or the lovely folks over at Connected Medicine put on an annual conference, and usually we're both there. And it's just unfortunate that we can't be in person.
Yeah, we're all living in this COVID reality of remote work and telehealth and Zoom calls, but great to see you in person here.
Yeah, no, this is will be fun. So, Mike, one of the things I wanted to talk to you about is remote patient monitoring. And I think you and Xealth are kind of uniquely positioned to kind of see what's happening and what's real in this market. So, want to just get your take on that. Where do you see remote patient monitoring going? Is this sort of a real thing or is this a fad?
No, absolutely a real thing. Xealth works with over a dozen of the leading hospital systems in the country: Providence, UPMC, Duke, Baylor Scott White, Mass Gen Brigham, Advocate Aurora, et cetera. And what we see, certainly in light of COVID, was a rapid rise of RPM solutions. Now, you know, Philips and ResMed chose to invest in Xealth, and so we've connected up their CPAP devices, we've done glucometers, we've done n number of remote patient monitoring scenarios. But especially in light of COVID, when you had telehealth, uh, every single disease state needed a RPM solution state. So
Right.
we've done a lot of work in maternity care, and a lot of what we've done to date was prescribe apps to patients that helped a mother and her expectations around gestational development, how she should be feeling through, months 2 to months 9, and it was more of an educational pursuit. But in light of telehealth, these healthy mom checkups that could be done virtually as long as you had the weight scale measurements and the blood pressure of the mom, then these healthy mom checkups could be done virtually. So RPM got stood up in cardiac care, maternity care, behavioral health. You might not often think about apps as being part of an RPM solution, but the PHQ-9, the GAD-7, these are clinical data points measuring the someone's mental health improvements or trend lines over time. These also play into RPM solution states. So we've seen an explosion of RPM both at the broad kit levels, Vivify, VitalTech, Validic, as well as the individual apps and devices that manage disease state RPM solutions. So it's just blossomed and bloomed. And I think COVID drew a necessity out, but you're seeing the reality that this can improve longitudinal real-time patient care.
And was there Mike, was there a movement towards more use of RPM technologies even before COVID? Like, were you seeing this before the pandemic hit that people were kind of, moving towards more use of this kind of technology?
Yes, although a bit piecemeal, like Vivify, got bought by Optum. We'd launched them at UPMC as integrated into clinical workflow. And a lot of these solutions were only against their capitated patient populations. But, in a typical fee-for-service world, a lot of hospital systems did not necessarily feel the clinical need or had the financial incentives to do the RPM solution state. But in terms of the telehealth now being reimbursed, you needed to have these RPM solution states in order to collect that reimbursement. Was you did a remote diagnostic that ascertained how you might provide a care recommendation to this patient. So that's where we saw a massive expansion of that at the provider workflow level. We also saw, just in terms of patient convenience, some cardiac care stuff at Duke. They were drawing patients in from a 200-mile catchment area for complicated cardiac procedures. And then instead of forcing that follow-up visit, couldn't you be able to do such in terms of some diagnostic device data? We also, at Providence, we stood up a COVID-specific RPM solution to reduce ED visits. Now, Seattle, where I'm based, had the first cases of COVID in February, and in March there was a massive rush to ED visits for people who had a sniffle. now. So how do you remotely monitor a patient and only bring them in for care when they're started to code? So we were shipping out to patients in partnership with Twistle, a vendor, the pulse oximeters and temperature thermometers, so that we could bring that device data back into clinical workflow and only draw in the patients that had the coding trends to bring them into an ER, acute scenario. So it's just blossomed all across the service lines, use cases, and creativity. And now that some of the relaxation around telehealth, the other thing that I would also say, just what we've seen with our very large provider systems, is they're quite jealous of the first dollar capture. And increasingly, they want to stand up their own risk-based arrangements, ACOs, Med Advantage plans, their own health plans, and expand that. And they also recognize that they can't take on that risk unless they have cheaper tools for managing patient care and the RPM in order to intervene more to control costs and escalations.
So Mike, maybe you can help me understand very quickly, where does Xealth play? Like, what does Xealth do? Can you maybe explain that to our listeners?
So Xealth is a platform to enable clinicians to prescribe and then subsequently monitor patient activity in a range of third-party tools and services. So we've integrated almost 50 different vendor solutions that span from patient educate the patients around a surgery or procedure, all the way through to apps, diabetes management, behavioral health, maternity care, pre-op, post-op surgery prep, and then the PTOT, MSK solutions on the rehab recovery side. We've integrated a dozen different devices across glucometers, CPAPs, RPM kits, other device, pulse oximeters, other device readings, and then just generically services, almost social determinant of health. We did Kroger meal delivery kits for COVID positive or suspected patients. We've done meal delivery for post-op recovery, especially bariatric surgery, get them started on a healthier lifestyle eating habits. We've done transportation rides. We've done e-com and pre-surgical product fulfillment. So our platform is pretty broad in whatever the clinicians believe provides more beneficial patient care. We can enable the engagement to that patient and then the subsequent monitoring of the patient usage against all of that. And importantly, trigger alerting to the care teams when app or device data or compliance thresholds aren't met, and it warrants escalations to the care teams to intervene.
So because of this work, I mean, you're in a pretty unique situation to see kind of where RPM and those kinds of devices and the technologies come to play. Is there anything you've seen where or trait where organizations have done this particularly well? Is there something that, hey, rolling it out this way, or an approach, or a mentality? Is there any sort of common thread that you're seeing to say, hey, when people do this, it seems to go really, really well?
Well, we represent the will of the doctor, the trust of the doctor. And when it's the doctor, the clinician, the nurse, the MA, that trusted patient relationship, asks a patient to engage in something, we have data showing anywhere from 4 to 20x higher activation rate and retention rate of the patient against that activity than what traditional insurance companies are able to get their members to do, or employers are able to direct their employees to do. So using that leverage of a doctor's recommending you to do something drives incredibly high usage and engagement. Oftentimes, we often refer to ourselves as the SureScripts for digital health. SureScripts being the e-prescribing platform for medications, and I believe it does 90% of the med routing in the US healthcare industry. We want to have that level of ubiquity on digital health prescribing. And when you think about that, because we close loop and measure the patient's engagement with all of that, we ultimately want to be the benchmarking of digital health effectiveness in the US. And since we're working with the leading provider systems, we've integrated dozens of different vendors. Many of these vendors we've launched, 3, 4, 5 different systems. We're able to aggregate best practices of what's working. And when we think about digital health in the future in RPM, so much of it plays into behavioral change, which has cultural and ethnic and language and age and gender kind of segmentation corollaries. And so ultimately, we think over time that you're going to see segmentation of diabetes solutions that work best for, elderly Hispanics or, African American or women, or, the segmentation is going to be essentially infinite versus the one size fits all. So that's one realm of activity that we see playing into a future strategy role. Another is when you think of med prescribing, a clinician needs to click a button.
Right. We're
able to automate, in addition to doing that manual, enrollment, we're able to automate against pre-appointment, pre-surgery, post-discharge with some new diagnoses. If the hospital system has clarified a rule and has enough confidence that anytime they see a patient coming in for X, let's send them this in front. Or anytime someone gets discharged with this new diagnoses, let's enroll them in app Y or device, Z. Right. So that automation reduces clinical burnout, the workflow, the efficiency, and generates massive scale level activity. We've certainly during COVID times, we started reaching millions of patients, 100% of patient activities at many different systems across what they were trying to get their patient populations to either learn about or actually do in managing better patient care.
Well, as a marketer, I like the whole comment about segmentation, right? Because the closer you can get to the culture, the approach, the language that someone is used to, the more likely it is you're going to get through to them. And in your case, or in your clients' cases, it's getting through to them to stay on the regimen, to use the device, or to take part in the care plan that they've come up with. So I love it. I love that, hopefully soon we'll be able to see a lot more personalization and customization of these programs to these unique populations.
Yeah, I think it's inevitable, especially, as you go back to that, there is an element of behavioral and cultural change required, and there's no capacity for one size fits all against that. I mean, everything else is devolved into some segmentation, either on the delivery side, the wellness coaching, the meal recommendations for healthier lifestyles, or all the way through to entirely separate app stack and company and formation that is focused on a certain patient population and does it extremely well. And we think with the Xealth platform, acting as a power strip to the hospital system, what's the difference? You can have one diabetes vendor or 8 as long as they're proving effective results against those patient populations.
Now, just a final question on RPM before I launch into something else with you. I've heard that RPM may need a redefinition or redefining, because I think most people think about RPM, or when they think about RPM, they think of devices only. They think about the glucometers and the pulse oximeters and so forth. But increasingly, apps and just software are part of the RPM world. Is that something that you're seeing as well in terms of, or is it still pretty much device-based?
No, absolutely. There's a broader scope to it. Now, I think a lot of people, when you say remote patient monitoring, like, oh, it's a device and people could simplistically also associate that with Apple Watch or Fitbit, but we've rarely found that clinicians care about that level of device data, right, unless it's packaged with a program to improve lifestyle, weight management, diabetes management, hypertension. It has to be built into a program trying to address a disease state. We have done, again, a number of like device specific RPM solution stacks, but, Omada, Livongo are managing diabetes. They also have glucometers that, associated with theirs. And they also have, how are you feeling today? And, they start trending against, behavioral health solutions and PHQ-9 score levels. So it's broader than just device data. It trends into apps that are managing disease states. But then as we contemplate RPM on behalf of our provider customers, We do shared decision-making forms to patients. Are they ready for the surgical procedure, or what is their birth plan? We do questionnaire forms for patients, PROs, patient-reported outcome forms for patients, consent forms. Capturing all of this data and having the clinicians able to document it, access it, read it, interpret it, all of that feeds into a broader definitional level of remote patient monitoring and digital health and patient care. And we think the Xealth platform flexibility enables a broad-based execution against these strategies.
You talked about lifestyle change, and you mentioned it a little bit earlier around behavior change. One of the programs that Xealth was involved in was a smoking cessation program over at Duke. And after you got involved, I heard that the Duke program saw significant improvement in that program. Can you maybe describe that for us?
Yeah, no, absolutely. I mean, back to chronic care and behavioral change, smoking is obviously one of the more expensive problems in the U.S. healthcare industry, but also decidedly difficult to get a patient to engage in quitting and smoking cessation. So back to that automation scenario, we intercept 100% of Duke's patient visits, and we intercept the appointment scheduling feed, and we've got the ability to say, hey, John's coming in for an appointment on Tuesday next week. Is there anything we should be aware of to prep this patient? And the rule that we created with Duke was, has this patient indicated prior tobacco use in the prior 5 years? And if so, we want to send them a very discreet message. And I say tobacco use because it could be smoking, it could be chew, packets, any number of tobacco modalities. And what we send to the patient pre-visit is, hey, John, glad you're coming in to see your clinician. You've indicated prior tobacco use. Here's a video around the importance of addressing this in your lifestyle and health. And then after the patient watches that, would you like to engage further on different modalities of quitting? And we write that data back to the hospital system's EMR, and that enacts, so that's an RPM solution state. And then that enacts workflow to engage with that patient very specifically about ways of quitting. And we've seen over 25% increased enrollment into the specific tobacco cessation programs that Duke has on offer to help these patients quit and address this. And we launched it on a trial basis, and now it's expanded system-wide across all of Duke. That example of use case care gap analysis is being used at multiple other sort of care quality gaps on a prioritized basis of what Duke wants to engage with patients pre-visit to get the patient's readiness, willingness, and participation in them making their own care choices, in addition to what the doctor might recommend retroactively.
It sounds suspiciously like a nudge, like, based on somebody's a prior answer to a question about tobacco use. You're giving them this sort of nice nudge to say, hey, we've got these programs available, not really trying to push you into them, but should you want to, because of a healthy lifestyle choice you want to make, lots of options for you. And you saw a 25% increase.
Yeah, absolutely. It was incredible numbers. Duke's been very thrilled with that. We've got at Providence advanced directives. The lack of having advanced directives often leads to a lot of excessive end-of-life care, treatment. And at Providence, we're intercepting that same appointment scheduling for annual wellness visits. So you've got an hour, associated with this visit with a patient. Hey, John, we've seen that you're over the age 65 and you don't have an advanced directive on file in the EMR. It's very important for you and your loved ones to consider. Here's educational material should you have any questions. Here's links to download the forms. Now, Providence is in 7 states and there's different rules and regulations, so we walk through separate procedures. But the entire goal is to bring the signed, notarized, witnessed advanced directives into that appointment visit to get uploaded into the EMR and put it on file. And we've increased that engagement level 600%. Now, smoking cessation, advanced directives, end of life, confronting your own mortality. These are not the same levels of, happy expectant mom, that absolutely wants to engage with her care and be very, very
proactive and
compliant towards her management. These are people and topics that often get swept under the rug, a little challenging to address. And here we are addressing the patient pre-visit. Hey, do you want to engage in this because it's very important for you? And then we've shown exponential level increases in participatory behavior by the patient, leading to the clinical outcome that was hoped for in these workflow use cases.
And do you think is it simply because you're providing educational material, or is it more that you're just showing or demonstrating care that, hey, like, we care about you, this is why we're suggesting it? Do you have a sense as to why the giant increase of both these types of programs?
So it's multi-factor. First off, it's your doctor asking you to do something. So that has a higher engagement level than any member marketing, any employer directed, any television advertising or brochure or flyer or whatever. So it's your doctor asking you to do something, and with the explicit knowledge that he, she is going to be monitoring whether or not you did it or didn't do it. So that's the first, is the clinician recommendation and the sentinel effect of the guilt factor that the clinician is going to be monitoring your activity against that. The automation against the very targeted specific behaviors, not 100% of patients that have ever indicated tobacco use, but it's the ones that have said, yes, I want to target addressing my smoking challenges, or yes, I just needed that nudge, that reminder, the actual link to download those advanced directive forms to bring them in. It was convenient because I already scheduled the appointment. You made it easily accessible, handy, and informational to that activity. So your right place, right time, right messaging, back to your marketing and advertising level, but you're addressing a very acute clinical need against the patient's preparation and tolerance and willingness to participate in that activity.
I love it. I love it. And those are phenomenal. Congratulations. Those are phenomenal results. I'm sure your clients were very happy.
Well, we enact the will of the clinicians in the hospital system. What are they trying to address, and how can they do so at scalable mechanisms? And oftentimes that's in automation procedures. And we just build the workflows that they think are going to best address patient populations. Now that we've done that at other systems, we're launching comparable programs. So it's back to the best practices. We're working with leading provider systems. Hey, Xealth, what have you done in behavioral health? What have you done in smoking cessation? What have you done in surgery prep? And we can represent how other leading systems have done it, and the vendors and the success metrics and the tweaks, the learnings along the way, to start off with what we perceive to be best practice against managing disease state management in virtual and digital health tools.
So if we sort of look a year from now, or maybe 6 months from now, Mike, and we get together again, what will have changed for Xealth and for the market for healthcare in general that you're hoping to see, or that you're working on right now?
So multifold. Well, I mean, first off, we're going to sign more customers. We're going to launch more use cases. I think that's a given. Given the contracts and other customer pipeline opportunities that we've got.
Awesome.
Telehealth and virtual health are here to stay. It is ballooned open in the world of payer and employer worlds. Mm-hmm. Providers, I would say, have somewhat been a little slow to adopt. Some of that are the financial incentives. But I think the providers are recognizing the acute need to have more RPM and virtual care, solutions managing different disease states on that front. And then lastly, I think that the country needs to revisit the reimbursement around digital health, because whereas you're seeing every commercially insured patient having a range of, oh, we've got a virtual diabetes management solution, something for behavioral health, something for smoking cessation, something for hypertension, you name MSK, you name it. The world of CMS reimbursement has been slow to adopt, reimbursement mechanisms. So you're seeing this healthcare inequality exist. Oh, I'm sorry, you're on Medicaid. The only way you can get, you can get care is a face-to-face appointment. We might be booked out for 6 months, but we don't have a digital health tool that's covered for you. And so I think you're going to start to see CMS revisiting the reimbursement structures around digital health solutions, especially in chronic care, because it's more convenient. It's proving just as effective results as some, virtual, or this asynchronous virtual world is going to produce the best of both worlds. But yet it's not being covered at scale at the CMS levels that I think are necessary to provide more broad scale, equitable patient care across the country. You're in Canada, you would probably have your own point of view against that, but I think the US is also coming to recognize the equitable needs on that front.
Yeah, I mean, we do have the communist healthcare system, sorry, the universal healthcare system. But I mean, equity is still an issue, of course, because when it comes to these kinds of technologies, not everyone has access to them, even though the healthcare system up here is free. So, but it's interesting. I mean, I agree with you. I think that telehealth is here to stay, and I think it bodes well for RPM, which we started talking about here, Mike, because I think the two aren't necessarily tied inextricably together, but it represents each other, right? The fact that people have come to accept and acknowledge that telehealth is necessary for care, I think bodes well for people who are in the remote patient monitoring world, because it's very similar. Instead of having someone come in, I can just try a diagnostic, right? And
Yeah.
I can prescribe them a device rather than have them travel 200 miles to come see the specialist, right?
Yeah, we've
fantastic.
launched a number of maternity care applications. They all 100% went to diagnostics needed to be included there, because you want to be able to track the weight and blood pressure of that mom to help ascertain healthy fetal development and maternity progression, et cetera, on that front. But you just multiply that against behavioral health, diabetes management, hypertension, MSK solutions, all of that just blossomed in terms of the diagnostic data needing to get written back into the EMR for clinical decision-making, care protocols, and quite honestly, some of it's for reimbursement-driven mechanics as well. So it's hard to ignore the financial incentives that drive some of the choices here in U.S. healthcare policy decision.
So Mike, if someone wants to find out more information about Xealth, where should they go?
Xealth.com. We have a Twitter feed. I'm happy to have a direct conversation. My email is mike.mcsherry@xealth.com. But certainly we're happy to engage one-on-one with clinicians. But our customers are the large provider systems and any IDN or provider organization trying to improve patient care through digital, virtual, and remote patient monitoring kind of capacities to improve patient care.
Awesome, Mike. Well, thank you so much for being on the program today. I really appreciate you talking to us about RPM and about your work at Duke and other organizations. It was very enlightening. Thank you so much.
Well, thank you very much, Colin, and thank you, Healthcare IT Today, for having me on board today.
This has been Colin Hung with Healthcare IT Today. Thanks for listening.